first thing is like, can you get in contact with Leticia's parents? And I was like, what? Why? They were asking me if I could, and I asked them no, why? And they told us I should contact them so we can go say our final goodbyes. One of the only times I ever sat down outside in the parking lot, and I was just crying the whole time, praying.
You have COVID-19. It's the news no mother-to-be wants to hear. And for one woman, not only did she contract the disease, she has no memory of delivering as she spent the next 2 months in a coma. The device that served as a last-ditch effort to save her life. Coming up now on the Morning Medical Update. And good morning to you. It is Friday, May 20th. Thank you so much for being with us here on Facebook, YouTube, and on Twitter. Coming up, just like winter, summer comes with certain risks, and our expert shares how to prep your aging loved ones to minimize their risk of fall and injury as they get out more in the upcoming months. In about 15, Dr. Dana Hawkinson will join us with the latest COVID headlines and COVID numbers. And now you are looking live at a special machine a brand new mother had to spend nearly 2 months on after contracting COVID-19. It is called ECMO, and it helps your heart and lungs. We're going to show you how it works to save lives, plus talk to nurses who were responsible for this one woman's care. So get your questions sent in to us on YouTube, Facebook, and email us at the Medical News Network. You can find links to all those right there on your screen. What was supposed to be a joyful time of their lives, expecting baby number 2, quickly turned to the fight of Leticia Celestin's life after contracting COVID-19, 34 weeks pregnant.
And I was just crying the whole time, praying.
Ron David remembers the moments and conversations as his partner, Leticia, lay intubated in the hospital, barely clinging to life.
The first thing is like, can you get in contact with Leticia's parents? And they told us I should contact them so we can go say our final goodbyes.
At 33 weeks pregnant, 24-year-old Leticia Celestin contracted COVID-19. She wanted to wait to vaccinate until after she delivered.
It started with a night I had like a fever and I was getting chills.
Leticia was admitted to North Kansas City Hospital and told she'd need an emergency C-section. Her condition quickly got worse. She was put on a ventilator and soon transferred to the University of Kansas Health System.
Good morning, Leticia. This is Kathy. I'm the chaplain that's been coming by.
Leticia was going downhill so fast, the family was on a first-name basis with the hospital chaplain.
She was so nice. She was the one that would always come visit her. Well, even when she got moved to a different room, she would always come find us.
And God, we pray that she will grow in strength each day.
They said that her oxygen levels for her blood was it was really bad, like low. But with the ECMO, it started to slowly climb up.
Doctors said Leticia qualified for ECMO. She qualified because all other options had ran out. An ECMO machine essentially acts as a patient's heart and lungs, pumping oxygen into the blood, giving the patient a last chance at survival.
They only had I think a handful of ECMO machines. She was one of the lucky ones.
COVID was taking everything from her.
Well, I lost my finger. These were all dead tissue, and then this one just fell off.
Leticia spent 2 months intubated, but finally opened her eyes.
There she is.
The loss of her fingers was nothing compared to the time lost with her daughter, Kaluna, and new baby, Stella.
Because I told them to post pictures right on the window.
We had to take it down because whenever she sees it, she would cry.
Ron and Leticia say they are grateful for their family and are hopeful the worst is now behind them.
We are joined now in studio by Dr. Drs Zorn and Dr. Steve Seitz. Guys, thanks so much for being with us today. How are you?
I'm good. I'm good. Thanks for having me.
You bet. Also, we've got the ECMO team joining us up in the unit. The 2 nurses who helped with Leticia's case, Annie D. Penaloza and Christina Genton, also joined by Director of ECMO Services, Dr. Bridget Flynn. We're going to get with you ladies here in just a moment. Alexis Del Cid is going to talk with them. So hang tight for us, ladies. And we want to talk with Dr. Zorn first. You first came in contact with Leticia initially. Kind of explain how her case came to be here.
So we got a call from North Kansas City that they had a patient there that was failing all the advanced therapies that they could offer with the current ventilatory support there. And she was in need of ECMO. They didn't have that capability there. And so we actually took our supplies there to go put her on ECMO because she wasn't safe to transfer. We couldn't even get her into an ambulance the way she was.
So let's talk about ECMO. That is a word I had never heard of until COVID, until I started working here in a hospital. I'm sure I'm not the only one. So tell us exactly what ECMO is. And then Dr. Seitz, I want to hear about how maybe you come in contact with that with your patients.
Yep. So ECMO stands for extracorporeal membrane oxygenation, and basically it is taking the bypass machine that we use in the operating room in order to do heart and lung surgery to the bedside in the ICU. So it's a smaller unit, but it facilitates gas exchange. So patients that can't get rid of CO2 and can't deliver enough oxygen, this takes over for them. It can also provide support for a failing heart. So it was designed as a bridge from either really sick patients coming out of heart and lung surgery or other patients like
So
that.
I hear lung, and I think of you, Dr. Seitz.
Yeah,
so your patients?
It's a funny deal, right? Because for years, ECMO in the ICU didn't work particularly well. In the last decade, that's really accelerated in the last 5 years, especially so. And now I think it's become kind of the standard of care for patients who are really at the end and aren't able to support themselves through other means. And the situation with COVID is especially challenging because we know that COVID can have some cardiac effects, but the main effect is on the lung. And because there's such a lung injury, the problem we run into is that in order to treat somebody's lungs and get oxygen into them, you have to put a lot of pressure into the lungs, and that pressure from the ventilator can actually injure the lung as well. What ECMO can do is it allows the lungs to rest because the machine helps get oxygen into the blood, and by doing that the lungs can rest and hopefully heal and recover. Otherwise, the ventilator itself can cause enough injury that people can be both injured from COVID and from the ventilator. When that happens, recovery is really difficult. ECMO gives you rest for the lungs. You can sometimes use them a little bit or almost not at all, and allows the lungs to have a little bit of recovery. It is a measure of last resort, though. It's got a lot of risk associated with the use, Trev.
Yeah. So anytime you're on a support like this with the exposure to all the surfaces of the machine, you have problems with both bleeding and clotting. As COVID does, even independently, just the disease process itself has issues with clotting.
So what were the conversations like then initially when COVID came to be 2.5 years ago, and we saw how sick these patients were and their grave condition, that ECMO would be the answer? Did it just make sense that this is where they would go?
So we got a preview with a flu epidemic before, and so we had a number of patients who had flu in the severity requiring ECMO, and so we had kind of a warning for that. Plus, here in Kansas City, we had a little bit of a warning of what happened in Europe and what happened on the coast before it got to us. So we actually bolstered our number of ECMO units. We didn't have enough for what we anticipated with it.
So the qualifications are high because these machines aren't just available anywhere and everywhere. There's not an abundant supply.
A couple of hospitals, KU does it, St. Luke's does it. I think does Research
Research
do it too?
does have it, yes. Yeah.
And so there aren't a lot. And in fact, during the height of the COVID crisis, we didn't have enough ECMO machines in Kansas City. We were turning down transfers because we didn't have any more ECMO machines left.
Yeah.
All right, I want to turn to the team that helped care for Leticia really round the clock, because that's what ECMO requires. Alexis Delcid is joining us with the nurses and the director of ECMO services. Tell us a little bit, Alexis, talk with them about what this was like for them and the experience with Leticia.
This was, I'd like to call them, if we can, the dream team. These nurses and Dr. Bridget Flynn, Annie and Christina, they worked around the clock with members of the team up here. They saved her life. This is amazing. I'm here in this room. Dr. Flynn, I want to start with you. Everything in this room is a piece of equipment that Leticia needed to survive, including you and Annie and Christina, our nurses we'll get to here soon. This is the ECMO machine, and you call it the heroic machine, the hero machine.
Yep.
Can you explain which parts of this machine were the ones that made sure that Leticia's lungs and heart were working throughout all this?
Yeah, definitely. So this, as Dr. Seitz alluded to, this is heroic measures. This is something not every hospital provides, and it takes a lot of training, a lot of credentialing, things like that to do this. So when you're looking at this machine, this was our monitor where we saw her flows on this machine. We saw what the machine was seeing inside her body. So that was that. The workhorse, though, of this machine, the little secret piece that keeps it going, does all the work basically, is this guy. And that's what we call the oxygenator. As they alluded to, it not only gives oxygen to the blood of the patient who cannot get their oxygen to their cells correctly, it also takes away carbon dioxide. So we call it a membrane lung. So it acts as a human lung. It's just a wonderful thing developed many years ago, but now it's the workhorse of this machine.
And this is for when ventilators don't work. There's a ventilator right behind there, which was no longer an option for Leticia?
So she was failing the most heroic ventilator settings they could offer. The problem is you can't just keep going up on a ventilator. Right. Especially sick COVID lungs are going to pop, and that could be a lethal problem.
Holy smokes. I want to get to Annie and Christina, our two nurses, to talk a little bit more about ECMO. And we've been chatting all morning long. Annie, I'll start with you. As we heard in Jessica's story about Leticia, there aren't many of these machines. So how do you make that decision which patient can be placed on ECMO?
Correct. So we definitely don't have that many machines. The people that make the decision would be like Dr. Flynn, our intensivist, and the cardiac surgeons like Dr. Zorn. There's very strict criteria that they have to meet, and so they'll meet with the patient, review all of their charting and everything, and see if it's an option for them.
And this was an option, Christina, because so much else was going wrong. And in fact, this was for her kidneys here behind her. So that was because her kidneys had failed?
Yes, yes. We call this a CRRT machine, a continuous renal replacement therapy. And we actually have the ability to hook it up to the ECMO machine that will allow us to filter the blood and take out the toxins and refill with everything that basically works as a kidney. So this right here is like a replacement kidney.
And then next to that is where all her IVs were.
Yeah.
Now this is not a normal amount of IV hookups.
No, just to help with sedation, medical, high drug therapy. We use all of these for her pressure systems that you can see on the monitor, all of our numbers. We use all of that as well.
And we're going to get more into Leticia's specific story in a bit. I want to go back to Dr. Flynn, though. Dr. Flynn, you think you've seen it all. Then we're in a pandemic. What's it like to have to make this decision so often with such a small number of the equipment? I would imagine we've all heard the word ECMO more than we ever dreamed we'd hear, especially you as a doctor. What's that like to navigate during a pandemic?
Well, it's hard because everybody wants to do the best for their patients. So we got calls from all over the Midwest down to Texas. Everybody wants to help their patients. Not very many centers have this capability. So it's a huge onus on us, but we approach it as a village. It's always a communication, a group talk, and we want to do what's best for the patient because while this can save lives, it can prolong death. And so we have to be very careful about how we make that selection.
Boy, I can't even imagine the load of responsibility on this healthcare team's shoulders. And they did it all right. Leticia is here and she's alive today to tell her story. When we come back, we're going to talk more with this team, this dream team, about what it took and all the factors that were going against Leticia, what made her case so special. I mean, we just showed you video in Jessica's story of a chaplain. We happen to have video of a chaplain coming in and talking to her. That's how dire it was. So we're going to talk more about that coming up in a little bit, but I'm going to send it back to you in the studio. This is a really cool place with some brilliant people.
Alexis, thank you so much. We do have a community question I want to ask Dr. Zorn. Erica wanted to know, how often during the surge did you need to put someone on ECMO? I mean, there were certainly no machines to spare, I would imagine.
So we had a couple of spare, but that was, as they alluded to there, it was a daily decision. We were getting consults almost daily, if not 2 or 3 at a time during the height of the surge. Not everybody met the requirements to be on, as they said, we had strict requirements just because it's not just the machines, but when you look in that ICU bed right there, remembering that there were 2 ICU nurses at bedside the whole time.
24 hours a day.
24 hours a day. And especially in the height of the pandemic when they came in still infectious, so it was full PPE precautions. So it's quite difficult to care for a patient with closed doors, everybody in max garb and trying to get in and out. And so it's not just the number of ECMO machines, but it's the number of personnel we have in the ICU. We had 4 or 5 at a time in there, and that means 8 to 10 nurses occupied just with the COVID patients, not taking care of the other patients in the ICU. So the demands are not just material, but it's also personnel.
Well, Dr. Flynn said it.
There were a lot of times when all the machines were on, right?
Yep.
And then we get a call from an outlying hospital, say, hey, can we send somebody else in? You couldn't do it. And then when you get this sick, this is great. This is a great story. But many patients don't survive ECMO, right? You're so sick. In fact, the majority don't survive.
Yeah, and they're on it for so long. It's not like you go on it for 3 or 4 days and come off. She was on for several weeks, and we have somebody who's been in there for 3 months right now.
Well, that's what I was going to ask you is when we were the original uses for ECMO, would people be on it for that long as well? So is it just because of COVID they were on so long?
Yeah, prior to this, the broadest use was quite honestly in the pediatric population when they had an extensive reconstruction and they would go to the ICU, and that would be kind of 24 to 72 hours, just allowing for heart recovery from a major operation or lung recovery from a specific injury. We never really envisioned using this for weeks and months at a time.
Dr. Flynn mentioned it takes a village. So when you, like for instance with Leticia's case, what part do you play? You actually do, there's like a surgery or something you have to do to get ECMO ready to go?
So it's a great question because quite honestly, the people that you saw in the ICU were the ones that do most of the work. The surgeons were involved in the decision making, and we put the cannulas, which are basically the connections to the bloodstream, to allow the device to work. And we work in coordination with the ICU team, but the majority of care is delivered by our intensivists and our nurses at bedside.
So
this is not uncommon. The surgeons are taking the glory, and all this. The medical guys are doing all the
right.
work. That's how it goes.
Yes.
To be clear, this is why we have those 3 women up there, because we want to see their faces and hear their stories.
This is the correct world order.
You do your important, you do your important job, and then you sit back and watch them do the work.
Yeah.
So we are happy to give them all the glory. So I want to take just a quick break from this story and ECMO to talk about COVID. I want to bring in Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control. Good morning on this Friday. What can you update us on with the numbers?
Numbers, again, still looking good in that single digits, 5 active infections, 0 in the ICU, 0 on the ventilator, and 7 in that recovery period. So again, our hospital numbers are still holding steady, holding low. I think that's all continues to be good news.
Couple questions about COVID. Of course, Dr. Seitz, jump in here on this one. CDC recommends you get tested for COVID before you travel. Seems to make sense. Good recommendation, you would say?
Yeah, they don't really give specific reasons. So here's what I'm proposing is, number one, you want to test before you go because you don't want to be ill on your trip. I mean, if you're going to a beach or going to do an event, you don't want to be at home ill. The other reason is, or at your hotel or wherever you may be staying, the other reason is they do still want to help reduce the rates of transmission, so we don't want you to go to those events and spread it more. The other thing, if you are going to visit people who may be more at risk of getting severe disease, that's another important reason as well. So again, this was guidance for travel within the United States. It's an urge or a recommendation, but I think those are really the main reasons, and I don't know if
I think that's right. We've said before that I don't know that travel truly spread. When you have widespread community transmission, is travel really going to be a risk? What is really, it's not the travel itself. It's what you usually do when you travel that's causing the issue. And so when people tend to travel, they also means you're going to go out into public settings, you're going to be around some new people, and they're outside their bubble. So that's really what this is about. But what I think we're seeing in general, Hawkeye, is that, and it's interesting, the wastewater testing now is really high in lots of parts of the country. It's as high as it was during some of the Omicron outbreaks, and certainly the Delta strain outbreak. So when wastewater testing has gone up like that, what we are seeing, though, this time, is that instead of the really rapid rise in the amount of wastewater testing turning positive for COVID, for SARS-CoV-2, is that it's a slower but very steady rise. So it's interesting because this Omicron is so transmissible, the BA2.12.1, but the rise in the wastewater testing is a little slower, but it is really picking up, Hawk.
Yeah, and I would certainly urge even more, if you are flying or going on a bus or train, wear your mask because, again, you don't want to get ill when you're there. And yes, a lot of people will have very mild symptoms, but we heard from Alexis yesterday, and I had another friend who is a hospitalist here who had it around the same time as Alexis. Both young people, but they were down and out for a week, and so you really want to try to avoid getting it while you're traveling as well, so that you can enjoy your vacation. And one of the best methods to do that is to continue to mask in those high population or high people dense places like terminals, airplanes, things of that nature.
I totally, I'll be traveling in a couple weeks. I guarantee you my mask is going to be on because of that. But I think what you're seeing, like in New York City, Earlier in the COVID crisis, I think they would have already put masks on. What we know is that there is so much weariness and just so much fatigue from the pandemic that people don't want to have to go back to that. And the thing we know is thus far hospitalizations haven't really taken off. Now some areas of the country they have. New York's starting to rise, Boston's gone up, other areas in the Northeast. As the hospitalization numbers rise and we get pinched for hospital services like we were in January, I think then we're going to see masks go back on. But cross our fingers, we're not going to see that because there is a relatively high rate of immunization, not necessarily booster shots, but immunization and people who have had COVID, that together we won't see the same severity of illness along, I think, with help, as you mentioned the other day, Hawk, Paxlovid makes a big difference. And there's 20,000 scripts a day being written for Paxlovid in the United States.
Yeah, and it's still working. Right now there's no resistance to that. It still does have effect on improving your symptoms and your chance of going to the hospital. But I think that's important. What you said about vaccination but not boosting, please, if it's recommended for you to be in that booster category, we know the circulation is high right now of the virus. Please go get that boost.
You know, I got my booster on this program on Tuesday. The next day I was out working out. I feel great. My shoulder's a little sore, but that's like any shot. And I would just urge folks, don't be late, don't hesitate. Get your vaccination and get your booster shot, because I think we're coming into a little bit of a bumpy few months and you want to stay safe. The next thing to think about is the booster for next fall. Little talk now from the FDA saying, gosh, I wonder if we can combine a booster with influenza shots at the same time. I think that would be great.
Yeah, I think this mRNA technology is going to allow us to do a lot of things with vaccines, but also other things such as therapies. But certainly we're talking about here for vaccine preventable disease and death, and I think it's going to be very good moving forward with the opportunities that we're going to have with this.
I was on a plane last week. I was the only one on the plane with a mask on.
No, seriously.
I kid you not. Really? I go, do these people know something I don't know? But I like it because I can lay back and take a nap and I don't look weird. So it was
your mouth is open with the drool hanging out.
Sleep comfortably. But isn't that strange? So wear your mask if you're going out of town.
I'm going to wear my mask because I'm already sick.
Have you had to travel much during the...
I haven't for the past couple months, but we have some coming up, and I'm going to be wearing a mask.
Yeah, full gear on. All right, last quick question on COVID. Just Dr. Hawkinson, we were talking about this the other day. North Korea, suspected COVID cases approaching 2 million. What does that say worldwide, and certainly how might that affect us?
Yeah, number one, I think we always have to be wary of the information that does come out of there, but I think it is going to be very devastating for that population that is already devastated by famine, lack of resources. It's so unfortunate. I think they are now trying to get some cargo planes in and out of China for assistance. I don't know to what extent, but it's going to be very bad. It is very bad. But we'll just have to keep an eye on it. And it's just unfortunate for the North Korean people.
We all want to be done with COVID, right? We want to be done with all the different ways. The reality is it's here to stay, and it's going to have it's going to be here for years. And the key is to try and stay safe over the long haul. And I think that and to not get long haul syndrome. We know that up to 30% of patients who have COVID can still get long haul. We know that vaccination reduces that. We know that vaccination reduces your risk of death by 90%, 80 to 90%. That's a big deal. And man, I know there's some hesitancy. It is important to note, though, that over 90% of adults have now had at least one shot with for COVID-19.
Yeah, and I'd also like to add, if we're speaking about North Korea, again, we know one thing we've always been asked here on the show is what can I do to improve my immune system? We know there are those products out there that are pushed to improve your immune system. We've really said, what are the best things to improve your immune system? Number one, get good rest, try to live an active lifestyle, but also nutrition. And we know, again, the malnourishment that is so present and prevalent in North Korea, we know that does have a significant effect on your immune system. So that combined with everything else, lack of adequate hospital resources and capacity, is just one more thing that will increase that individual's risk of severe outcomes should they get COVID-19.
But there's probably not as many McDonald's.
Probably not.
Speaking of McDonald's, I have a question here. Sandy wants to know, weird question, but if COVID can be detected in wastewater, why can't someone come up with an easy, cheap way to test it in the toilet? Sorry,
well,
I had to ask.
No, it's actually a good question. I had to stop and pause. It can be detected in wastewater. It's a big process. There's a lot of testing, so it's probably not as simple as just doing your own COVID swab. That
Just
works out
drop
pretty
like
well.
a little
Yeah,
tablet in there?
I think you're good just to do the little home nasal swab. I think that's coming, and someday maybe we'll get cool nose sprays that help us. That I was reading actually about this morning about some of the nasal sprays in development with antibodies to help protect you against COVID, but we're probably 2 to 3 years away from that.
And I would not use the swab in the toilet then on your
No,
nose.
I don't think that would be good.
Then on your nose, no.
Do not do that.
That's why we tune in for these good tips. Thank you so much.
Stay safe out there.
We're talking about ECMO. I know you have to get going, Dr. Seitz. Do you have a couple more minutes that you can add to the conversation? Dr. Drs Zorn is also with us here to talk about just some of those tough decisions that healthcare workers were forced to make during the pandemic. Just on a personal level, tell me a little bit about that, just what it's like to have these conversations, and there are families wanting answers, and these patients are in such dire situations. What was it like personally for you?
So that was tough. We've talked a lot about how difficult it was being in the ICUs with so many sick people that were sick for so long and had such a poor prognosis. And the ECMO decision did not come lightly, because when you'd go up to go see one consult, you'd walk past 15 to 20 other people who were also on ventilators at a high setting. And you knew that this was honestly the last resort. Mm-hmm. And so if you said no, then the palliative care consult was going to come next. And so that's really difficult, and it's balancing resources and knowing that we only have so many machines, we only have so many beds, and it's a really hard call.
I bet.
And it's also, as Dr. Flynn mentioned a moment ago, of there's the concept of prolonging life, transitioning over to prolonging death. And if you look at the CT scans on some of these patients, they have such extensive destruction of their lungs already. And while the ECMO machine can keep them alive, it can't fix the lungs. And there are so many patients that were just beyond being able to recover and have a meaningful quality of life.
Fair to say that you've never been in this type of decision making before?
No, it's very different. It's very different. I mean, we all have end-of-life decision making with patients. But as far as scarcity of resources and the surge hitting with so many patients at the same time, and making decisions, quite honestly, on patients you could never see. As she mentioned, getting calls from Texas and Idaho, and because they'd called every ICU along the way trying to find a spot for their patient, and not having a spot for them.
Anything specific or unique about Leticia's case when she was brought here to the health system? You said everybody knew about her case. She had just had a baby. She'd been on it for so long. What was so unique?
So there were a couple of things. We had a number of patients, that were transferred in that, quite honestly, didn't survive the transfer. They were on such high levels of ventilation that they had to be flipped from the position they were in, put on a transport ventilator in an ambulance, brought here, and quite honestly, they didn't survive the trip. And we knew that was the case with her. So first, postpartum. Okay, so that hits everybody, at an emotional level that you can't quite explain. So everybody was, willing to go even further than normal on that one, kind of extending some of our indications. But then it being in a different hospital, so at a place that we couldn't transport. So there was actually 2 of our perfusionists, Doug Korth and Jason Fenton. We basically loaded up my truck and took some supplies over to North Kansas City and got her in the OR there and put her on ECMO there, because that's the only way we were going to be able to transport her. So postpartum and at a remote location were the kind of unique things about her.
So fair to say miraculous recovery. When
So
you see that story and you see her walking in a park,
yeah,
holding her babies, what does that do for you?
Well, that's awesome, because I hadn't seen that story, and I hadn't seen that footage, and so that's awesome. And so quite honestly, we lose contact with them, because after they get out of the ICU, they go to rehab and all those other things, and we don't see that part of it. So this is awesome to get to see some of that footage.
See her there hugging her daughter.
Absolutely.
She hadn't seen her daughter in 4 months, since even before, just when she was sick, because her partner didn't want her little 4-year-old to see mom laying there and have to explain to her, knowing that they didn't know she'd ever make it home.
Yep. And we saw the pictures of her in their room, and we saw the pictures of her baby, but that's the first I've seen of.
All right. So we want to check back in with the Dream Team. Alexis is joining us up in the ECMO unit with the women behind Leticia's survival and just talk a little bit more about some of the, more specifically, the risk involved and some more details about Leticia's case. Alexis?
Yeah, I'm here in the room that has been replicated to look like the exact room where they saved Leticia's life with all the equipment. We have Dr. Flynn, we have nurses Annie and Christina. I'm going to start with Dr. Flynn because we know the case was so complex. She was pregnant, COVID positive, requiring ECMO. Dr. Flynn, how many other patients have you had that met those criteria?
So it's an interesting question. It seemed like that second surge, which I kind of put her into of COVID surges that we got called upon for lots of ECMO, it affected pregnant women because in that surge we had 3 different either pregnant or newly delivered patients that needed ECMO. One of them we got through, she was at an outside hospital, so with lots of communication got her through just on the ventilator. And they delivered her baby, and that made things better, actually. The other 2 were here, Leticia, and the other one who also survived. So it is a testament to the young, healthy body that can survive an insult like that.
So only one other patient, if I'm hearing you correctly, besides Leticia, was on ECMO?
With pregnancy.
Pregnancy, right.
Yeah.
That was her case, and they both survived?
Yeah.
That is remarkable. How rare is that?
I think it's pretty rare. You know, definitely through the years that's been case reports, but not often.
That is, and that's because of you and your team here. And speaking of, I want to talk more about just the sheer level of care, and this is where I want to speak with our amazing nurses here. Annie, I'll start with you. Can you talk to me about the level of care it takes and the teamwork it takes to care for a patient on ECMO that's also pregnant and COVID positive?
Yeah, so kind of what we talked about before, all of these machines in here are things that we're watching constantly for changes, things that need to be adjusted.
And Christina was showing us some of those machines
exactly.
as well. Does it take 2 nurses for each ECMO patient at all
Typically,
times?
yes.
And you were the 2 nurses that were kind of high-fiving, tag-teaming each other every day?
Yeah, Christina works days and I work nights, so we just kind of flip back and forth with that.
And how often do you overlap now? You work different shifts now, or days and nights?
Yeah, we're still days and nights, but yeah, we still, do the same thing every day, so.
Wow. And Christina, I want to ask you, in general, how has the pandemic and COVID impacted patient care in this area when it comes to ECMO?
Yeah, absolutely. So we want to make sure we protect ourselves, so we've made sure that we have all the protective equipment, the isolation gear, the respirator, the glasses in the room. Obviously, we want to make sure that nothing's getting out, so we have the HEPA filter in here to help clean the air.
And let's show people the HEPA filter while you're answering a question. That thing is huge. I didn't know what that was. I had to ask you.
Yeah, which is great. It just adds an extra security in hopes that we can help filter the air if COVID is in the air while we're caring for the patients, helps protect them and us. And then also just making sure, visitor policy, that was a big deal, and then communication with family as well. Wanted to make sure we had a means that even though they couldn't talk, the family could still communicate with them and see them, and if they wanted to. So we had the Zoom meetings, and obviously with our team as well, the multidisciplinary team, we were able to communicate with families that couldn't be here, that were either, couldn't come in themselves or,
And that's the emotional component, juggling so many things, and I just want to drive that part home. When we talk about the HEPA filter, while most of us were able to stay safe and isolate and stay home and put our masks on to go to the grocery store, these team members you see here were right up front, close and personal, 24 hours a day with the sickest of the sick patients, because that's what they love to do. They want to care for people. This is a huge risk, and they've never been through a pandemic before. I want to bring it back to Dr. Flynn. When it comes to Leticia, how do you support the post-delivery care for, you have a woman who gives birth by C-section, I believe, but she still needs all sorts of medical care after you give birth, and she's now hooked up to ECMO. So how do you do that? How do you care for her post-delivery?
That's a great question, and one that very few centers have to think about. But so it's a village. Here at KU Med, everything is a village. We've got people who are experts in their field, including OB. So our OB colleagues helped us out so much. They would come down, and of course, I don't know if many know that this machine requires anticoagulation, meaning it needs to thin the blood so that workhorse doesn't clot off, that oxygenator. And so with a postpartum patient that just had major abdominal surgery called C-section, she's going to bleed. So we needed a lot of help from our OB colleagues, and they helped us with medications. They helped with procedures at bedside for her. And it was a village approach.
Wow. So you have a machine that's supposed to thin the blood on a patient that won't stop bleeding.
Yeah.
And somehow you made it work with your teammates
Yep.
and the OBGYN.
It's a minute-by-minute process when you have somebody
smokes.
that's sick.
I can't stress enough how remarkable it is to be in this room in person and get to see all the different equipment and technology. Everything looks so intricate, and yet I'm with a team that knows this room like the back of their hand. Come on in, guys. Come in. I want to bring it in for a hug. You know, I mean, I just think I don't even feel like I deserve to be standing here with this team, but this is the team that saves lives and puts their lives on the line every single day when it comes to patients so they can go home to their families. It's really a special place to be. I can't say that enough. Jess.
Oh, Alexis, this is why we do what we do and they do what they do. So, and I hear what Dr.
Exactly. I've been saying that all morning. It's just, we just going to put the spotlight on them.
Right.
We'll see what they do. That's our job.
We will definitely keep our day jobs for sure and stay out of their way. And
yes, please.
Dr. Trip Zorn admits you give all glory to this team that you're looking at right there. Right?
Oh yeah, no, we'll have fun with this for a little while.
Oh, good. Okay, good.
Yeah.
We have got a few community questions that I want to get to real quick. No reporters on the line? Good? Okay. Well, then let's get to some good questions. Someone had a question. Isaac wanted to know if Leticia's baby tests positive for COVID. She was COVID positive or in the isolation phase, right, Dr. Zorn, when you did the initial surgery.
Yep.
Wanting to know if the baby had any complications or anything like that. But I'm going to turn it over to Dr. Hawkinson. What do we know about when a mother delivers in that isolation period? Any thoughts on if that passes on to the baby?
Yeah, I mean, so from what we understand and know, you really don't have transfer from mom to baby. If baby does get it, it's usually in that postpartum period when the baby is being held so close to mom and you have that close exposure to the respiratory secretions. Again, what are we talking about here? We are talking about respiratory failure, ECMO. Typically, that has been going on now. That has taken time to develop that. Again, the best thing that we know, the best evidence that we have is that you really have that active viral replication for those first 8 to 10 days of illness. When you start to have that respiratory failure and that severe lung disease, usually at that time it's the inflammatory stage and you're really not having a lot of active viral replication go on during that period as well.
Adil wants to know, Dr. Zorn, how late in the pandemic did they start using ECMO? He says, I didn't think I started hearing about it until 2021. How soon did you realize this could be used?
Oh no, it was very early. As I said before, we got a little bit of a clue with the flu epidemic, which was I think 2 years previous, in which we had a fair amount of ECMO patients, and we had to reevaluate our capacity and how we would manage it. And again, we had a little bit of a warning from Europe and from the coast because they got hit with it hardest before we did, and so. We made the decision at that time. We ramped up our inventory and we kind of initiated protocols. And Dr. Flynn and her team had already kind of evaluated how we would manage the ICU with the increased number of patients. So it was present very early on.
Dr. Hawkinson, Isaac says he tested positive for COVID yesterday.
Ooh.
Of course, he says, I am vaccinated and boosted.
Yeah.
How long is so-called hybrid immunity? How long is it? How long does that last? Have you heard of hybrid immunity?
Yeah, basically what that means is you've been vaccinated, you're up to date with your vaccines, but you've also had natural infection. So you're also having that immune response to the actual virus and those particular things on the virus, not specifically just the spike. If this is your first infection and you've been vaccinated, typically the guidance right now with the CDC is you really don't need to get another booster if you're in that booster category for about 90 days. Certainly I've been recommending about 8 to 12 weeks, which is almost to that 90-day. That hybrid immunity is a term that's being thrown around, but that's essentially what that means is now you have an immune response to those other parts of the virus that your body hasn't seen just through vaccination.
All right, and last quick question from Joellen is if you could just go into a little bit more detail about the minutes indoors unmasked with close contact. I'm sure you're going to say it has to do with if you're vaccinated or not. Is it still about 15 minutes? What can you tell us?
Yeah, I don't think anything has been changed as far as that guidance with exposure. Probably not much more to say other than there's really been no update to the guidance as far as what do you consider exposure, and it still is that same time period in that close encounter, especially in that indoor space.
Okay, now this really is the last question.
Yeah.
Are you still wearing your goggles when you travel?
I don't recall that. I think I traveled in the winter, and I did, to the chagrin of my son. I don't know if I will be this time. Again, it's all further protection. It's not a big inconvenience for me, so I still haven't made that decision yet, but I will certainly be wearing my mask.
So you just do it to bug your son?
Yeah, it's fun to embarrass your teenage
yeah,
kids.
Hello, duh. That is why we have them.
That's right. That and to mow the lawn.
Yes, yes. Okay, so let's get to some final thoughts. Great conversation today. Dr. Zorn, I'm going to start with you. Just final thoughts on our conversation today.
Well, I think it was fun getting to see the story about Leticia. I think it's great payback. You saw the team in the ICU, and those are the ones that run to the problem, not away from it. Mm-hmm. And so they went right to it, and they take care of that problem every day. It is another example of great teamwork, because there was an awful lot of people involved in this. A really difficult situation, and a patient who basically couldn't be transported safely with conventional means that. Now gets to take care of her kid and watch him grow up. So
Isn't that great?
Yep.
I think we forget how much that everybody has a job to play, and you're right. You don't see that patient all the way through, so you don't get to see these
Yep.
happy endings very often.
Yep.
So when you do, I'm glad we were able to bring that to you today.
Yeah,
so
it's a bonus this morning.
Good
so,
bonus. All right, good to have you today. Thank you so
very
much. Alexis, I'm going to send it out to the Dream Team and let you wrap up and get some final thoughts from them.
All right, Dream Team member number 1, Annie, our nurse in the Dream Team. Final thoughts for you?
Kind of just what they were saying. Once our patients leave the ICU, we don't always get to see how they're doing. So it's just really amazing to see how Leticia is doing now.
What a great success story.
Yeah.
Christina, what's on your mind? What are you thinking as you stand here today?
It's, gosh, like we talked about, we really didn't get to see the baby or like any of her other children. So for them to be connected again and to be together, that's awesome. It's incredible. We always wondered if that day would come, and it did. So it's a miracle. It's amazing.
Best possible ending.
Yeah.
And we have Dr. Flynn here, who's been guiding us through our tour of ECMO and this life-saving room and team. What's on your mind today? This must feel so good.
Oh, it does. I thank the production team for putting together that video to see Leticia, because I loved seeing that. We didn't see her like that. And just thankful to work at KU, where we have this capability, our nursing colleagues who are the best in the world, and the whole village that it takes to do this kind of stuff.
It's incredible to see the team in action and to get to see the results of that.
Alexis, thank you so much. Great reporting this morning. Great to meet those ladies. Dr. Hawkinson, your final thoughts.
So I would talk to Isaac as well. Talk to your doctors and think about getting prescribed Paxlovid. Again, the best time you have activity against the virus and your illness is within 5 days. Certainly, I believe out to 7 days you can have it, but the sooner the better. And new news about the boosters for 5 to 11 now has been recommended by the CDC, so I believe today or tomorrow you should be able to get those boosters for those young children at this point in time after that CDC meeting yesterday.
Thanks so much. And headlines this morning for families of newborns struggling to find and get infant formula. Well, there is some good news. President Biden has invoked the Defense Production Act to speed production of formula. The president is also allowing the Defense Department to use commercial carriers to import the formula here to the United States. While for some it's good news, health system pediatrician Dr. Steve Lauer says this is only the tip of the iceberg.
The frustrating thing is that it's very challenging to help with. The formula is just not there. We do see this every day in clinic of families who are not able to get the formula that they're used to seeing, and therefore at a time when also gas prices are high, they're having to drive around to different stores, so they're using up time, gas money, trying to find the food for their babies.
The state of Kansas has implemented waivers to provide flexibility and making more formula products available. State leaders have also approved more formula products for use by Kansas WIC families. Summer is almost here, and just like in the winter, there are some risks, especially for our aging community. Dr. Jessica Callender-Rich says open communication and preparation can help when caring for your aging loved ones.
In the summer, there are falls, whether people are out traveling or they're out at their kids' or grandkids, I should say, baseball game or whatever it is. And having that awareness, especially on the uneven ground, can be really important. There's this delicate balance between saying, I really don't want you to fall. Be really, really careful and sort of hovering and really ensuring that we're being supportive and getting our message across in a way that's well received. And the truth is, it's not always going to be well received anyway. But even saying things like, hey, let's start walking a little bit at a time. Can we walk every day now that it's spring, so that when you go on this big trip, or when we go together on this big trip, you're ready to keep moving and can keep up with us a little better.
Great advice. Thank you so much for being with us today. Don't forget, you can catch our shows anytime by logging on to Facebook, YouTube, and Twitter. Go out and make it a great Friday. Have a great weekend, and we'll see you back here Monday at 8. Coming up Monday on the Morning Medical Update.
Helping cancer patients using a beam of energy. It's a big day for us here at the Health System. I'm Jill Chadwick. Join us Monday as we go inside our new Proton Therapy Center as the first 2 patients begin treatment. See you at 8 on these social media channels. Subscribe to our Morning Medical Update and Open Mics with Dr. Seitz podcasts. Now, everywhere podcasts are available.